afternoon, all. Again, it's my privilege to welcome you all delegates who have been following us in our series, Medical Care Psychologist. It's my privilege to welcome Dr. Ramachandran Gopinath, who was a former of Nizam, one of those first cardiac anesthesiologists reputed internationally and nationally. Currently, heads the department of SI Medical Care as the chief anesthesia and we all know that Dr. Ramchandran Gopinath, excellent teacher and great human being. He has been my mentor in several phases of our life. He has been part of our several conferences that we have conducted, and all his deliberations and contributions it's among us. So again, sir, we are privileged to have you with us uh, today for this webinar series. About this critical care webinar series, the was when I came across this critical care clinics that was published recent past, like in the March 2023, it got published. Lee Fisher being the chief editor, and this was a clinic that was dedicated to anesthesiologist, a perioperative physician, and the emphasis was on critical care for the anesthesiologist. And all the topics were excellent in terms of perioperative medicine, perioperative critical care. And we thought we should upgrade our knowledge and also at the same time just deliberate whatever we know to our fraternity. And with that objective, we started this webinar series. Today is the third webinar series, and Dr. Kiran is with me to co-moderate this session. We have interesting topics lined up for today's talk. One is by Dr. Mayura on the intraoperative ventilator strategies, then post-operative cognitive dysfunction and delirium in surgical intensive care unit. And third is when the patient develops post-operative respiratory failure and ARDS, how do we optimize and what strategies do we have? How do we prevent it? I'll be dealing with that. And finally, again, perioperative acute kidney injury by Dr. Neha again. So I'll just hand over the proceedings to my colleague, Dr. Kiran. But before that, I would just like to request Dr. Gopinath to say a few words before we start. Over to you, Dr. Gopinath, sir.
Thank you for those very kind words, Sunil. I hold you in high esteem for your contributions too, because you are one of those pioneers in obstetric, and of course you did your cardiac anesthesia too, but you branched off and you have won laurels for quite a lot of stuff, and especially for your wonderful, what shall I say, attitude of learning, 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 and teaching, and learning and teaching. I had a small quotation in my room when I was in Nizams: the teacher is a student forever. And I believe that as long as you hold that as part close to your heart, nothing like it, you will always continue to prosper. And we never stop to learn. And like we say, anesthetists don't expire. You just you lose gas. So that's the only thing that happens. But the topics are wonderful. I think the series, this is very sort of welcome in terms of day-to-day care, and they're all practical issues that you have brought out. I'm sure there must be many more in this series, but that's great. So I think keeping updated is what is important, like you said. So we'll carry on, please. You're muted.
Good afternoon to one and all, and those who are watching this live webinars session. Welcome to the Perioperative Critical Care webinar web series part 3. As Sunil sir told about this, these topics are from the anesthesia clinic books, which was published in March 2023. The emphasis is mainly on the critical care topics which are relevant to the anesthetist. So let's begin with our first topic: intraoperative ventilatory management of critically ill patients by Dr. Mayura Bandari. She did her MBBS from Seth GS Medical College and KEM Hospital Mumbai, and DNB from Jeslok Hospital and Research Center Mumbai. Over to Dr. Mayura.
My topic for today is intraoperative ventilatory management of critically ill patients. We are all very We are all very familiar with this picture, right? Gentlemen, this is no humbug. This was the words uttered by the dental surgeon, Dr. John Warren, the first demonstration of anesthesia.
Pardon me, we are not able to see any slides. Yeah, that's it. Okay, we got it. Thank you.
So this is we are all very familiar. This is the first demonstration of anesthetic being used for any surgical procedure at Massachusetts General Hospital in Boston. The day was 16th October 1846. The dental surgeon John Warren had said, "Gentlemen, this is no humbug," and the anesthetist being Sir W.T.G. Morton. From that day till today, we have indeed come very far. That with recent advancements in anesthetic and surgical management, we are taking ASA grade 3, ASA grade 4 patients with better outcomes in post-surgical period. Hence, the risk-benefit ratio is improving for these patients, and hence my topic today, intraoperative ventilatory management in critically ill patients. Now, to know this, what all do we need to know? I've tried dividing this topic in. First is respiratory physiology, so the normal respiratory physiology. Second is lung mechanics. Third being changes in the lung mechanics which happen with general anesthesia. Fourth being the changes in lung mechanics in critically ill patients. And then lastly, we will discuss how all these factors put together, we can formulate a consensus-based guidelines to ventilate our critically ill patients in operation theaters. Now all of us are breathing normally, right? So we are breathing at our normal tidal volume. We are not using any accessory muscles of respiration right now. So this volume is the tidal volume. It is about 300 to 500 mLs. Now let us all take a deep breath inside. Now you are using your accessory muscles of the neck, accessory muscles of the chest, right? So this is the inspiratory reserve volume. This is around 3000 mLs in males and around 1900 mLs in females. Now let us all expire forcefully. This is expiratory reserve volume. Again, you are using all your accessory muscles of respiration, like the neck muscles, the external intercostals, everything, along with your regular muscles of respiration, like the diaphragm. So this is the expiratory reserve volume. It is around 1100 mLs in males and 700 mLs in females. Now these three volumes can be measured normally by spirometry because we are exhaling all these volumes. One lung volume which cannot be measured by spirometry is the residual lung volume. This is the amount of air which will remain in our lungs even after a forceful expiration. Now, how do we measure residual volume? There are three techniques. One is body plethysmography, nitrogen washout test, and helium dilution method. I will not go into the details of all this. This is just an overview of pulmonary function tests. When we are measuring any lung volume, what are we measuring? We are basically measuring the amount of gas present in the lung at any given point in the respiratory cycle. Residual volume is of great importance to an anesthetist. It is the amount of air which remains even after a forceful expiration, right? So if the residual volume is increased in a patient of, say, obstructive lung disease, then this patient, when you're taking up for surgery and when you're ventilating this patient, there is a higher chance of barotrauma, volutrauma to these patients, a higher chance of pneumothorax in this. Also, what we need to remember is that the lung pressures are transmitted onto the heart, which is high. So hemodynamic changes also will be more pronounced in these patients who have obstructive lung disorders, basically because of an increase in the residual volume. Now coming to the lung capacities. What are lung capacities? They are basically an addition of all the lung volume measurements. So inspiratory capacity, it is basically tidal volume plus the inspiratory reserve volume. Total lung capacity is the tidal volume plus the inspiratory reserve volume plus the expiratory reserve volume plus the residual volume. In lung volumes, two volumes stand out. One is the functional, in lung capacity, sorry. One is the functional residual capacity and second is the vital capacity. First, I will like to talk about the functional residual capacity. Functional residual capacity is the amount of is the amount of gas which remains in the lung even after a normal expiration. This is the amount of gas which is used for gas exchange when we are not actively breathing, and when we anesthetize a patient, functional residual capacity is the one which decreases, which I will discuss further. Vital capacity is the expired lung volume after a maximal inspiration. Vital capacity is very important for cough reflex of a patient. Vital capacity has to be at least 3 times the tidal volume to have a good cough reflex. We all know the importance of cough reflex for anesthetizing a patient and especially for extubation. This is in short what I said, inspiratory capacity, functional residual capacity, and the vital capacity. Now coming to lung mechanics. So how do we exactly breathe? Knowing normal lung mechanics helps us to know what exactly happens in critically ill patients. This is the picture of the lung, the diaphragm. As you can see, as we all know that the pleura has two parts. One is the parietal pleura, which is attached to the diaphragm and the chest wall, and the visceral pleura, which is attached to the lungs. So there is an intrapleural space, potential space, which is created between the two. Now there are two forces which are acting on this pleural space. One is the elastic recoil of the chest wall, which is acting outwards, and second is the elastic recoil of the lung, which is acting inwards. Because of these two opposing forces, there is a negative pressure which is created in the intrapleural space. Normally this pressure is around minus 2.5 centimeters of water. Now what happens when we start breathing? When we start breathing, signals are sent to the diaphragm starts contracting. With it, it will pull down the parietal pleura, which is attached to the diaphragm, right? Also the chest wall will start recoiling. Because of this, what happens? That the intrapleural pressure, which was initially minus 2 centimeters of water, the negativity of it increases. So it becomes around minus 4 centimeters of water. Because of this negative pressure, the negative intrapleural pressure is then transmitted into the alveoli. So the alveoli, where the pressure gradient was first 0, now if you see, there is a pressure gradient of minus 1. So flow of air occurs from the atmosphere into the intraalveolar space because of this negative gradient. The flow is always along the gradient, right? At the same time, you can see that we start inspiring. So the tidal volume will slowly increase to 500 ml. Now, as air enters the alveoli, the pressure in the alveoli increases and it then slowly equals the atmospheric pressure. At the same time, the diaphragm also stops contracting because it gets the signals from the respiratory center. Now, once the diaphragm stops contracting, the intraalveolar pressure slowly starts increasing and the chest wall also starts recoiling. So once the intraalveolar pressure becomes positive, we start expiring and hence the tidal volume starts coming down, as you can see here. I hope I'm clear about it. So this is the same thing that I've explained in breathing cycle. Another important concept is the concept of lung compliance. Expansibility of lungs per unit increase in transpulmonary pressure. It is determined by elastic forces, basically change in volume per unit change in pressure. Combined compliance of thorax and lungs is 110 ml per centimeter of water. Compliance of lung alone on an average is 200 ml per centimeter of water. Elastance is a property which is opposite of compliance. Lung compliance helps us to ventilate our patients, which I'll come to later, to determine the PEEP and other factors. Now coming to how these lung mechanics that I've explained change in general anesthesia. Now when you administer any general anesthetic, there is two things definitely happen. One is loss of muscle tone and second is loss of reflexes. Because of loss of muscle tone of all the voluntary muscles, there is decrease in minute volume. There is the diaphragm definitely moves upward. Plus for general anesthesia, we make the patient supine. So the FRC, which is the capacity which I've already described, which helps in gas exchange when we are not actively breathing, it is reduced to almost 1 to 1.5 liters. Now, as this FRC approaches the residual volume, there is more and more atelectasis which is happening at the alveolar level. So blood is flowing, but the alveoli are collapsing. Hence, the shunt fraction increases. Another thing which general anesthetics also do is that they cut off the hypoxic pulmonary vasoconstriction which is normally present in the lung. Because of this, the shunt fraction will further increase. Also, anesthetics, they reduce the drive of the peripheral and the central chemoreceptors. Hence, the respiratory drive is reduced the amount of CO2, the shunt fraction is increased, and the patient becomes more and more hypoxic. There is increase in VQ mismatch. Now added to this, in critically patients, we have a picture of ARDS, pleural effusion, diaphragmatic splinting due to intra-abdominal pathology or postoperative pain, sepsis, pneumothorax. So from all this, we can understand that in a critically ill patient, the respiratory dynamics are totally different than what it is in a normal patient, and hence we need to take special care. Now, what is the definition of post-op pulmonary complication? There is no particular definition to it. It is basically an umbrella term which will encompass any change in respiratory system which occurs within 5 to 7 days of administering of general anesthesia and surgery. Now, if we want to reduce something, first we need to know how to predict it. So when a patient is coming to me in the PAC clinic, how do I go about it? How do I know that, okay, this patient has a higher chance of postoperative pulmonary complications? So this is just a chart. I will go through some indices later on. So what are the risk factors? So if it's a patient who tells me that, okay, I smoke a lot, I have COPD, I have congestive heart failure, or he has a lower EF, he is a ASA class 3 patient, I know that, okay, he may have some post-op pulmonary complication. Then I go through his investigations, right? So I check his saturation at room air. So any saturation at room air less than 95, or if he's anemic, he has low albumin count, then the predisposition for post-op pulmonary complications is higher. Then I see what surgery is he posted for. So especially an open upper abdominal surgery, vascular surgery, any surgery where the duration is more than 2 hours, emergency surgery. So then I take into consideration that, okay, yes, this patient may have post-op pulmonary complications and I need to take certain care intraoperatively, which I'll be coming to later. Okay, so then I plan my anesthetic management. Now also in anesthetic management, all these factors which I've written here, I will describe in detail. So if I have to administer the patient general anesthesia, he will be definitely more prone to post-op pulmonary complications. If I have to give him a high inspiratory oxygen fraction because of maybe his low saturation, then again the same thing. I have to give him fluid. Too much fluid has been given. I have to give him too many PRBC transfusions. All these intraoperatively also tell me that, okay, this patient I have to watch out for in the surgical ICU. So these are a few, the first is the assessed respiratory risk in surgical patients. This study was carried out in Catalonia in Spain. This helps us to predict postoperative pulmonary complications. They have taken 5 parameters. One is age, one is preoperative saturation, third is respiratory infection in the last 30 days, fourth is duration of surgery, and fifth is whether it's an emergency surgery or no. I will not go through the entire table, but you can see that points have been allotted for every parameter that I have discussed just now. Now in ARISCAT score, as it is called, a score of less than 26 shows that there is not much predisposition for post-op pulmonary complications. A score of between 26 to 44 shows that there is a moderate risk of post-op complications, and more than 44 is that definitely this patient I'm expecting to have some complications post-op pulmonary wise. The second indice is the LIPS score, which is lung injury protection score. So any patient who comes to me for any high-risk surgery, is in sepsis, shock, acute abdomen, traumatic brain injury, any score of more than 4 is at a higher risk of acute lung injury, not exactly post-op pulmonary complications, but then acute lung injury will cause post-op complications, right? The third score, that is the early acute lung injury score. This is basically for hospitalized patients depending on their oxygen requirement. So here also a score of more than 2 has a higher risk for post-op pulmonary complications. Now, how does exactly, when I'm ventilating my patient, how does mechanical injury take place? First is barotrauma, elevated pressure applied to airway causing disruption of lung alveoli. Second is volutrauma, over distension of respiratory apparatus. Atelectrauma, that is repetitive opening and closing of the smaller airway. And fourth is biotrauma, that is the inflammatory mediators. Go a bit in detail about this. All of us know that the alveoli are lined by epithelium. Capillaries are lined by endothelium. So basically, yes. So when we are mechanically ventilating our patient, what is happening on the capillary side and what is happening on the alveolar side? On the capillary side, the endothelium, the proteoglycans and the endothelium, if we ventilate our patients with too much volume or too much pressure, they give in, causing increased capillary leak. Hence, there is interstitial edema which is called. Now, this interstitial edema, which is present between the alveoli and the capillary membrane, it causes inflammatory mediators to rise, like the metalloproteinase, which I have pointed here. Hence, so this is physiological mechanical ventilation and injurious mechanical ventilation. So this is your capillary side and this is your alveolar side. So here, as you can see, I said there is more and more capillary leak as the strain of mechanical ventilation increases and the capillary leak increases. Because of this, the wet to dry ratio increases and interstitial edema will increase. Now, what happens on the alveolar side? Alveolar side has sodium, potassium, ATPase channels which are present. Now, if I am ventilating my patient with too much pressure, they will stop functioning. Once they stop functioning, they will not clear the fluid as effectively as they were earlier. Also, because of all this, the surfactant distribution, which is essential to keep the alveoli patent, that suffers. So you have a patient whose alveoli are now atelectatic and who has landed up in interstitial edema. Now, giving even a little more fluid to this patient will land up the patient in hypoxia and post-op pulmonary complications. How can we reduce the same? So intraoperatively, how can I take care that this happens less? First is alveolar recruitment with PEEP. Now this is something which we all do. PEEP is something which has to be titrated as per the risk-benefit ratio. It depends on the type and duration of surgery, the position of the patient and the comorbidity. All know that ASA 3-4 patients who don't have ARDS, if we give too much PEEP, there can be change in hemodynamics of the patient. And hence we need to be careful when we are giving PEEP. Now there can be a manual PEEP which we can give or a ventilator driven recruitment maneuvers which we. So I'll be discussing 3 maneuvers. One is the back squeeze maneuver where we take the patient on manual ventilation. We increase the opening pressure up to 40 centimeters of water for 8 seconds. Now this is the graph which comes when we do that. The A graph. Yeah, this is the back squeeze maneuver. So here you can see that once we squeeze the bag manually, the pressure will rise up to 40 centimeters of water for a period of 8 seconds. So this is good to recruit alveoli. What is seen is that once we release this pressure, again the alveoli get de-recruited. So this is not really recommended. Also in critically ill patients, when for 8 seconds you are pressing the bag at a very high opening pressure, you are predisposing the patient for any hemodynamic changes also. There can be severe bradycardia, severe hypotension which occurs in these 8 seconds and the patient may land up on inotropes. Now coming to the B part, which is stepwise increase of tidal volume during volume controlled ventilation. So in this case, what we do is that we keep a positive index, that is PEEP is set at 12 centimeters of water, the RR is set at 8 breaths per minute. Tidal volume is very slowly increased from 8 ml per kg in steps of 4 ml per kg until the target opening pressure is 30 to 40 centimeters is achieved. We give 3 to 5 breaths at this pressure and the PEEP is kept at 12 centimeters of water. Afterwards, we can again come back to our normal settings. But what happens with this, it is seen is that sometimes there can be some hyperinflation and then again atelectasis may occur. And as we all know, when there is hyperinflation with atelectasis, there is, like I just discussed in the previous slide, it causes more mechanical ventilatory strain at alveolar level. So the third mechanism is stepwise increase of PEEP, which is most recommended. Stepwise increase of PEEP at a constant driving pressure of 15 to 20 centimeters of water in pressure controlled ventilation. The PEEP is increased in steps of 5 centimeters of water up to 20 centimeters. After 3 to 5 breaths at a PEEP level that allows achieving the target inspiratory pressure, PEEP and tidal volume are adjusted to the respective desired level. This is what happens to the lungs at the end of inspiration and expiration. So the first picture here is low tidal volume and low PEEP. The orange area, atelectatic area, the yellow area, the cream colored area is the normal ventilated lungs. And here you see the over distended lung. So when we keep a low tidal volume and low PEEP, there is atelectasis both at the end of inspiration and at the end of expiration. So this is definitely not recommended. Now when we keep a high tidal volume and a low PEEP, what happens is that at the end of inspiration, atelectasis is there, there is no over distension. But at the end of inspiration, there is a lot of over distension and over inflation. So there is a lot of collapse of the smaller airways and over distension of the airways, and this again causes a lot of mechanical ventilatory strain, which is not good for our patients. So we go with low VT, high PEEP. In this, there is a bit of over distension, but the atelectatic area is less, and over distension is there both at the time of expiration and inspiration. Now it is up to us how we titrate this PEEP. I will come to that in the slides which follow, so that over distension is reduced, right? Because atelectasis is not there. But at least what is happening here is that the smaller airway, they are not again and again collapsing and expanding, and hence the strain of mechanical ventilation is definitely lesser. Now, how to alter the PEEP? As I said in the previous slide, we need to know how to keep the PEEP at the right level. So here the role of driving pressure comes in. Now, the difference between plateau pressure and PEEP is your driving pressure. Now, there is a concept of functional lung size, that is the amount of aerated lung which is available for gas exchange. Now, in a patient who has a restrictive lung disease, the functional lung size is definitely lesser. So we need to maintain a driving pressure in a way. If we keep the driving pressure very high in this case, we will cause barotrauma to the patient. So driving pressure can be used to set PEEP by balancing recruitment and over distension. Generally, driving pressure is kept at 13 centimeters of water. Now this next graph that I'm showing is how we can arrange both our driving pressure also and PEEP also. So we are plotting volume against pressure here. As you can see, this is in pressure control ventilation, okay? So as you can see, once we increase the pressure, slowly, first there is no increase in volume. Then at the lower inflection point, there is an increase in volume with increase in pressure. So previously, here the alveoli are collapsed. As the pressure slowly increases, at the lower inflection point, the volume starts increasing. Then there is a linear increase in the pressure and the volume till the upper inflection point.
Sorry to interrupt you, Mayura. If you can use the mouse as pointer, because for watching, they will not be able to see this mark.
Okay, sorry.
Pointer.
Yes, sir.
You can use the mouse.
Yeah. Okay, sir. So here we can see the alveoli, right? So when we plot a graph of pressure against volume, initially when the pressure rises, there is no increase in volume, right? And the alveoli are collapsed. At the lower inflection point here, there is a slow rise in volume and it linearly increases with the pressure till the upper inflection point. So this is where our alveoli are getting recruited. Now after the upper inflection point, there is no increase in volume, even though we are increasing pressure. So then if we increase the pressure further, the alveoli will get over distended. So both our driving pressure and our PEEP should be somewhere between the lower inflection and the upper inflection. Fourth point is mechanical power. Now when we are ventilating our patients, we are transferring some energy from the ventilator to the respiratory system of the patient. This is directly proportional to the lung damage. There is a very complicated mathematical formula which defines mechanical power, but I have not put it here because I could not make sense of it. But yes, it is dependent on the square of the tidal volume, it is dependent on the PEEP, and it is dependent on the compliance of the lung. So mechanical power, PEEP will definitely, it is directly proportional to the mechanical power. So when we are using PEEP, we are automatically increasing the amount of mechanical power that we are giving to our patient. But what we are doing, how we are balancing it out, is that we are increasing the compliance of the patient's lungs also. So it helps in reducing lung damage. Now this is how we can plot the pressure versus time curve for mechanical power. Mechanical power, it basically what it does is that it helps us know the stress index of the mechanical ventilation that we are doing to our patient. So here you can see this straight line which is there. So here, as the pressure increases, there is a constant compliance. So the stress index here is 1. Now, if it goes up, okay, upward concavity of the pressure time line, it is decreasing the compliance and it is increasing the stress that we are giving to our patient. Similarly, on plotting the pressure time curve, if there is a lower deflection, that is a concavity in the curve, we are helping the patient out by decreasing the stress index and improving the compliance. The fifth point is dead space. We all know about dead space. It is the volume of inhaled gas that does not participate in gas exchange. We have the anatomical dead space, which is of all the conducting airways, the larger conducting airways which are not participating, like the trachea, the bronchi, the major bronchi, which are not participating in gas exchange, and then the alveolar dead space. Now, when we are ventilating our patient, anatomical dead space we can easily reduce by reducing the length of the circuit, catheter mount, filter. We all know about that. How to go about reducing the alveolar dead space? Volumetric capnography is the answer to it. It can be used to optimize ventilation intraoperatively, as it gives us an idea about pulmonary perfusion and expiratory lung volumes and ventilation inhomogeneities. We are very comfortable with this EtCO2. We see it in our OTs every day. So here there's an inspiratory phase and an expiratory phase to it. The expiratory phase is divided into another 3 phases, and you have an alpha and beta angle. Now, how does the volumetric capnography differ from it? It does not have an inspiratory phase. Okay, so what we have is that we just have an expiratory phase. So the initial part, so here we are plotting tidal volume. So the patient is, say, exhaling, and we are plotting the CO2 from that exhalation. So initially the CO2 which is coming out would be from the larger conducting airways, right? From the trachea, the bronchi, and then this part is the part which will be coming out from the alveoli. So this is how we can know about alveolar perfusion, PaCO2, PetCO2, everything with volumetric capnography. Now we do have some advanced monitoring tools available. One of them is electrical impedance tomography. It is a portable device measuring electrical impedance over time dynamically. It helps to identify global inhomogeneity, regional strain, regional ventilation delay in a patient. It helps in ventilation in obese patients where lung mechanics are impaired in laparoscopic surgeries. Now, what exactly we do in it? There are about 16 to 32 electrodes which are applied to the patient, mainly after the 4th, 5th and 6th intercostal space parasternally, to monitor the lower lobes of the right and the left lungs. Basically, we give high and low voltage current and measure the surface voltage. Tissues will transmit the current easily, but gas will not transmit the current as easily. So this is how we can know about over-distension, under-distension, recruited alveoli, de-recruitment. Now the disadvantage include interpatient variation, cost, the setup and the training required. Esophageal manometry and lung ultrasound. Transpulmonary pressure. Earlier when I had shown the diagram of the lung with the 2 pleura, that is the parietal pleura, visceral pleura and the intrapleural pressure, another very important gradient is transpulmonary pressure. It is the pressure difference between the alveoli and the pleural pressure. Now a rough guideline of the pleural pressure, we take a balloon, we take a catheter with an attached balloon to it and we put it in the esophagus. The depth is generally 35 to 44 centimeters, and to confirm that we are in the right place, we can check for cardiac oscillations. If cardiac oscillations are not present, we'll have to change the depth of the catheter. Now the balloon in the esophagus, it estimates the pleural pressure. Now this also can be used to adjust PEEP in the patient. Expiratory transpulmonary pressure to be kept slightly positive to keep the alveoli recruitable. Now, what is the biggest advantage of this method is that it can be used to measure respiratory mechanics bedside in spontaneously breathing patients in ICUs as well, as transpulmonary pressure can be calculated based on pleural pressure. It can be used to set PEEP in obese patients, laparoscopic surgeries, and it can also be used to deliver a set tidal volume. Now here you can see we have used, like, basically the patient is flat and the PEEP is 14. Now once pneumo is created, we have had to increase the PEEP so that the transpulmonary pressure or the esophageal pressure here remains constant. This blue area here represents the transpulmonary pressure, and the alveoli which are now recruited. So to keep it constant, we have had to increase the PEEP from 14 when the patient is flat to 18 when the patient had pneumoperitoneum to 20 when the pneumoperitoneum is in Trendelenburg's position. Similarly, these are the magnetic resonance images of patients. So above is the preoperative scan and below is the postoperative scan of 3 patients on the first day of postoperatively day 1 who have undergone abdominal surgeries. So if we have adjusted the PEEP with all our maneuvers, we have seen that the pleural effusion and atelectasis is greatly reduced in these patients. So what are the take-home points? And implementing a LPV strategy in OR include both low tidal volume and use of PEEP in ventilator settings and avoid the use of low tidal volume without PEEP. When monitoring driving pressure, target driving pressure that increases compliance or to a goal of less than 13 centimeters. When performing a recruitment maneuver in OR, look for evidence of atelectasis and recruitability by using the stress index and avoid using recruitment maneuvers in patients with overdistension. I've already discussed in detail about the back squeezing, the stepwise increasing of tidal volume and stepwise increasing of PEEP techniques. The stepwise increasing of PEEP technique in a patient who is ventilated by pressure control ventilation is highly recommended. When inducing anesthesia and providing mechanical ventilation for our patients with obesity, limiting atelectasis starts with induction and patients should be intubated in 30-degree head up. That is where your FRC comes into play. So if you push the diaphragm down, automatically your FRC increases and you are increasing your time for intubation also in a difficult airway. When intubating critically ill patients in the OR at a risk of physiological difficult airway, we can use HFNC, non-invasive mechanical ventilation basically, and also give a propped up. Why 30-degree? You can even give a 40-degree head up and take a step to intubate your patient. If your patient presents in sepsis or with septic shock, use low tidal volume strategies in OR given the high risk of ARDS in patients with sepsis. When caring for patients with sepsis or septic shock who require mechanical ventilation in the OR, you should avoid worsening acidemia with permissive hypercapnia. If your patient is undergoing, say, a laparoscopic surgery and develops worsening gas exchange with insufflation, increase PEEP, try some recruitment maneuver. You can inform the surgeon, change the position for a little while, but we should not keep our patient in a way that he is more prone to post-op pulmonary complications. Now, coming to guidelines in sepsis, it's already what we've discussed. So, low tidal volume, higher PEEP, a plateau pressure of 30 centimeters of water, continuous infusion of NMBA is definitely not recommended. So, we can just take care of that. Now, there are some other studies like the Provelo study, that is protective ventilation with high and low PEEP in patients under general anesthesia, and the IMPROVE study, that is intra-op protective ventilation studies. These have been multicentric trials which have been conducted worldwide, and they also have come to the same conclusion that a lower tidal volume, a higher PEEP, and the use of recruitment maneuvers in our patients, which can be then calculated with the driving pressure, the mechanical stress during ventilation. All these help our patients post-operatively as well. So these are a few graphs which I had put the same thing that I've said. So after all this, let us all take a minute to close our eyes and concentrate on our lung mechanics before we move on. Thank you so much.
Thank you, Dr. Mayura, for elaborating biology, lung protection strategies. Very excellent deliberations. Day in and day out, we keep bagging our patient's lungs. But if we know the physiology and the mechanics involved, probably we can be more scientific. Before you talk, can I have some comments from moderator, Dr. Around, sir?
Yes, wonderful talk, Dr. Mayura, because you covered the entire aspect starting from physiology to current concepts.
Thank you, sir.
We all have to understand that, we have learned a lot from critical care medicine, and in fact, everything that is tried out today is adopted from what we have implemented in the critical care setting. The other good thing about it is all these mechanical or technological advances have translated into the perioperative care and incorporated into the anesthetic workstations. So we have all that you have mentioned. You can look at the inflection point, the volume loops, all of them. So the basis for all this is understanding physiology. Like you rightly said, so many events can cause lung injury. And something that we frequently forget is that we need to look at the FiO2 so constantly. Everybody has this habit of giving 100% FiO2 for pre-oxygenation, and the same at extubation. So these also contribute to PPCs in the and the perioperative period. And so giving a lower FiO2 mixture, and like you said, not just for bariatric surgery, any surgical patient, head up, anti-Trendelenburg, and give them a head up. So that helps to improve the FRC and reduce your complication. So the same thing should be adopted, and not look at saturation beyond 94, 95. They are good enough for all of us in the perioperative, especially in a critically ill patient. And of course, we do understand about mechanical power now. Lots of studies coming in. So the idea is that anything and everything that can contribute to lung injury should be minimized. So I think wonderful, but people should have access to higher end equipment for measuring all these that you have mentioned. So the least that you can do is to recruit intermittently. Like we said, bag squeezing, what we used to say, vital capacity breaths. Our earlier ventilators in 1980s, when we were training, they used to have a mechanical sigh or a button to give a sigh in between.
Absolutely.
So they were all wonderful devices. It's not that we did not know what they all did, but technology has helped us, and I'm sure everybody listening will adopt all the mechanisms that you have described for effective patient care.
But another thing
Thank
that
you so much.
my colleague is stuck or long surgery or graphics on, because at times most of our workstations they have ventilated graphics, and we don't take the maximum from the ventilated graphics as the operative or graphic change. Probably continuously visually monitoring graphic also gives us the stress index, as Dr. Mitra pointed out. So looking and practicing much more better than reading. So thank you, Dr. Gopinath sir, for the valuable points. We move on to the next talk. Yeah, request Dr. Kiran to Namagu.
Talk is on delirium prevention management in ill patients by Dr. Namagon. Did her MBBS from SPMC, did DNB from LTMMC in Mumbai, and she did her fellowship in neuroanesthesia from Medanta.
Good afternoon, everyone. My topic for today is delirium prevention, brain surgery. So, delirium has been known by many called as ICU psychosis, acute confusion state. It was first noticed by Hippocrates in 1400s and called as bad omen. In 1800s, it was called sickness. In 1960s, it was first noted and documented in the cardiac paper. So, how do we define delirium? Delirium is defined by the DSM 5 definition, which includes all 5 criteria of delirium. Any one criteria that is missing is defined as a subtype of delirium. It should include a disturbance in attention and awareness, a change in baseline fluctuating develops over hours or days, altered cognition, not explained by pre existing condition like Alzheimer's or Parkinson's, or an involving neurocognitive disorder like stroke. Evidence of systemic illness, substance or drug intoxication, withdrawal, or medication side effects should be present. There should be some cause or that should be attributable to delirium. Looking at a case load, we had around 266 million surgeries in 2015 with an estimate of 500 million surgeries in 2030. So with this increasing case load over the years, we also have an increased magnitude of delirium. So the magnitude of problem, looking at different institutional data, is from 5 to 52% of hospitalized surgical patients. An elephant in the room is how I define the delirium. Commonest neuropsychiatric syndrome in acute care setting. It is under-recognized post-operative complication. Growing population with an extended lifespan. The more we are progressing with healthcare sector, the more number of elderly, old age, frail patients we are getting. 50% in elderly post-surgical patients develop post-operative cognitive dysfunction. A Germany study, the Powell study, was done, a multicentric trial using 30-item frail index, which showed an significant association between frailty and delirium. Frail patients are at 3 times the risk. They're also at a high risk of prolonged hospitalization, readmission, and higher cost of care and mortality. These delirious patients tend to take out their tubes, tend to take out their interfere with healthcare, and then thus prolonging their length of stay and morbidity in the hospital. There was a study conducted, a retrospective study that was done at AIG by our department, in which we analyzed the data from 2020 to 2022 of 9873 post-operative patients, out of which 24% of patients had delirium. Most of these patients were on prolonged mechanical ventilation, had a very prolonged MI, and more than 15% of patients were post-COVID. What is the time frame of delirium and post-op cognitive dysfunction? When you look at the patients, a patient would develop delirium within 24 to 72 hours post-surgery. If left untreated, undiagnosed, this delirium can develop into post-op cognitive dysfunction and then further leading to post-traumatic stress disorder or depression in a long-term basis. What are the differential diagnoses of delirium? So delirium can be misdiagnosed. There is something called a sundowning, where the patient has impaired circadian rhythm due to increased mobilization at night, increased medical attention given with sisters taking out blood samples, administration of drugs, everything done during the night time. The patient is unable to sleep and thus is increasingly sleepy during the morning. Then there's Wernicke's aphasia, transient global amnesia, or the Kluver-Bucy Anton syndrome, where patient is blind and is unaware. Bifrontal lesion, stroke associated with multiple focal deficits. Non-convulsive status epilepticus, dementia. So dementia, the attention is intact and there is presence of a remote memory. Depression shows less fluctuations as schizophrenia, where the patient has some systemic delusions which can be diagnosed from history and taken from patients and patients. What is the pathophysiology of delirium? The exact mechanism of delirium is debatable. It could be neuroinflammation, where the blood-brain barrier is affected and there is increased neuroinflammatory markers. Imbalance of neurotransmitters, largely attributed to increase in anticholinergic activity as seen in patients of Parkinson's on anticholinergic drugs, and altered neuronal activity. What are the types of delirium? Types of delirium are hyperactive, hypoactive, and a spectrum of both, called as a mix. Since hypoactive delirium, the patients are calm, quiet, and withdrawn. So these patients do not attract your attention in the ICU and largely goes undiagnosed or underdiagnosed. Forms the major chunk of delirious patients in the postoperative period. Hyperactive patients are 9% of the total delirium cases. What are the risk factors for delirium? Main risk factors are patients on mechanical ventilation, patients who have been administered benzodiazepines in the pre-operative period, patients who have undergone an emergency surgery, have had an increased ASA or Apache 2 grade, patients who have had blood transfusions or hypoxia or hypercarbia during surgery or pre-operative aid, or electrolyte or fluid imbalance. So all these cases, all these things are risk factors for delirium. So once we know the patient is at a risk for delirium, how do we assess the patients in the pre-operative? So for liver transplant cases, what they use is called as a liver frailty index, where they assess the nutrition, muscle strength, and neuromotor coordination. High liver frailty categories were associated with subsequent worsening of disability. Then there was the Feud Frailty Index, where there were 5 points that were used: and unintentional weight loss, weakness, exhaustion, soreness, and low activity. So these 5 points are more than three criteria of more than three is associated with frailty. Different institutions have their own frailty criteria. Then there is the Edmonton Frailty Scale, where a scale of more than 4 is associated with increased post-op complications. In our ICU, in our department, we use something called, we use nutritional assessment using the GLIM criteria, a 6-minute walk test, and hand grip dynamometry to assess a patient if the patient is fragile or not, and is at increased risk of post-operative. Now, there were several studies done to assess delirium, its pathophysiology, and its treatment. One is the brain ICU study, where a longer duration of delirium was associated with worse long-term global cognition and executive functions. Then there is a mind ICU study, where patients who received enteral haloperidol, ziprasidone, or placebo, the results showed no significant differences in days alive. There is an upcoming study called the Brain 2 study, where patients are assessed using imaging and biomarkers and using CSF analysis, which would is showing really promising results. There's a study called the DEXA-SET trial, where 120 patients undergoing cardiac surgeries were studied, and scheduled IV acetaminophen was administered post-operative for 48 hours, combined with propofol and dexmed as sedative. Had significantly reduced in hospital delirium. So this study indicates that use of multimodal non-opioid analgesia benefits the patients and reduces the chances of post-operative delirium. So how do you diagnose delirium? First, you need to identify delirium using the confusion assessment method, the CAM-ICU score, and ICD-SC score. Assess the severity. The PADAS guidelines is the pain, agitation, disability, immobility, and sedation guidelines. So these guidelines recommend routine monitoring of patients in ICU. Assess the severity. So higher the score of CAM-ICU, worse would be the outcome. Although knowing that a patient is delirious and how worse the patient is doing on CAM-ICU score does not affect the treatment part. Then to look for a cause, to differentiate the delirium from other causes, we need to use imaging, EEG, functional MRI. So what is CAM-ICU score? In CAM-ICU score, firstly you check every patient for an acute change of mental status. So is the patient fluctuating in his mental status during the past 24 hours? If the answer is yes, then we check for inattention. We can use several methods. Either ask the patient to squeeze your hand when you say 1, 2, or every time you say 2, ask them to squeeze your hand. Or if, like the example is given here as save heart, where whenever you say A, so SAVEA, so whenever you say A, ask the patient to squeeze your hand. Is the patient attentive to your command? If the answer is yes, you assess the level of consciousness using the RAS score. Anything other than 0 on a RAS score, that is Richmond Agitation Sedation Score, anything other than 0, the patient is positive for delirium. Whereas if the RAS score is 0, the patient is quiet, is calm, then you check for the disorganized thinking. Ask them very simple basic questions like, will a stone float on water? Are there fish in the sea? If the answer is no, or if the answer is not correct, then the patient is positive for delirium. Then there's something called as the ICD-SC score, or the Intensive Care Delirium Screening Checklist, which is suitable for non-verbal ventilator patients. Score of more than 4 indicates delirium, and it is pretty time consuming for the nurse. So a word on alcohol withdrawal. Why is knowing about alcohol withdrawal important? A patient who has had a history of heavy consumption of alcohol, has not had alcohol in the last 6 hours or so, and the patient presents to us with autonomic hyperactivity, agitation, tremors, delirium, it's very important to know the history, because the management depends with the supplementation of benzodiazepines. The treatment is with benzodiazepines, whereas in delirium, benzodiazepines are contraindicated. So a score that we look at is the alcohol withdrawal scale, or the Clinical Institute Withdrawal Assessment for Alcohol. A score of more than 8 warrants management or treatment with drugs, You can use benzodiazepines, and for autonomic hyperactivity, drugs like beta blockers or neuroleptics or alpha 2. Preventive pathway. So, what are the things that we do at AIG to prevent delirium? We go for a pre-operative risk assessment, like I'd already mentioned, doing for a nutritional assessment, going for allaying anxiety using the new regime, that is nutritional assessment, endurance build-up, and allaying worries, where we check the patient or subject them to certain regimes for a period of 10 days to 1 month, and then assess them later for their endurance build up. Then pharmacological optimization, organ protective anesthesia, using targeted fluid therapy, using shorter acting anesthesia, multimodal analgesia, depth of anesthesia monitors, ultrasound guided nerve blocks, so there is lesser requirement of sedation, and ERAS E, where we mobilize the patient right from the OT table. So delirium management, it can comprise both of pharmacological and non-pharmacological methods. There have been 2 studies done, the HOPE ICU study and the REDUCE study, which have shown that use of haloperidol and atypical antipsychotic medications do not show a clear benefit with their use in management of delirium. Then there was a study, a significant study that came up was a SPICE 3 study, SPICE standing for Sedation Practices in Intensive Care Evaluation, which shows that dexmedetomidine, when used in old age patients, showed a positive result for delirium, whereas it was associated with higher mortality in younger patients. An upcoming study is a SPICE 4 study, where dexmed versus placebo is used for early sedation in old mechanical ventilation patients. Depending, looking at all these studies, a non-pharmacological approach is deemed much better than the pharmacological approach. Even if you have to use a pharmacological approach, haloperidol is recommended to be used for the shortest duration and the shortest dose possible. In non-pharmacological approach, we use something called as the ICU Liberation Care Bundle, which comprises of A, B, C, D, E, F approach. So what is this A, B, C, D, E, F? A stands for assess, prevent, and manage pain using the pain scores, the behavioral pain score or the ICU pain score. And B stands for spontaneous awakening and breathing trials that are used for faster liberation from mechanical ventilation. C stands for choice of sedation, using avoiding benzodiazepine, using multimodal analgesia, dexmedetomidine in high delirium risk. Delirium monitoring using CAM ICU trial. E stands for early mobility and exercise, and F stands for family engagement and employment. Coughs et al., that was a study done in 2022, has also added GHI. G stands for gaining insight into patient needs. H stands for holistic and personalized care. ICU, I stands for ICU design redefinition. So, how do you design your ICU to prevent delirium? In ICU design, you need to establish a baseline CAM ICU, reorient the patient, talk to them. Whenever you visit them, talk to them, orient them to time, place, person. Optimize their vision and hearing by providing them with glasses or hearing aid. Break the language barrier, use communicating technique, pictures, verbal or written. Use a visible clock or calendar, and daytime and nighttime schedule for every patient. Use all your blood sampling early in the morning instead of disturbing the patients at night. This is a patient, a well-lit ICU in patients who are high risk for delirium. Mobilize them. These are pictures from AI. Sleep management, light night or massage, comfortable physical environment, use noise, limit bed movement at night. Home favorites, if the patient has any favorite pillow or a favorite thing, that keep near. Remove any physical restraints for such. Arrange family to visit to provide some positive reinforcement to the patient. In patients who are delirious, encourage the family to stay a bit longer, and ask them to talk to the patient to provide reassurances to the patient. So, in summary, delirium is frequently un or underdiagnosed. Longer the duration of delirium, longer is the post-traumatic stress. It worsens with sedation, hypoxia, and sepsis. Our focus should be on managing its cause, orienting towards non. Thank you.
Gopinath sir, this is Dr. Kiran.
Yeah.
Sir, could you share your experience on post-operative cognitive dysfunction?
Yes, please. Thank you, Dr. Kiran. Especially coming from the cardiac surgical or cardiac anesthesia setup, it was a pretty common problem, and one has to understand that at least in the cardiac surgical setting, there are multiple insults, especially neurological and bypass. So there were lots of contributory factors for that setting. In the other perioperative settings, especially when we talk about frailty, POCD, or post-op delirium, you have an elderly patient coming for orthopedic surgery like fractures. So these highly vulnerable patients who have sleep disturbances, probably dementia, and other cognitive dysfunctions already associated. So these are some patients whom you need to look at very critically. And the idea is that yes, if they are in the perioperative care, all the tools that you have for assessment of possible neurocognitive dysfunction in the perioperative period should be implemented. The setup should be, you should have a counselor or a nursing staff or somebody in the preoperative area. Just a simple one we do here in our own hospital is a clock face to assess them in the preoperative period. So we ask them to draw a clock face and identify the digits. So that has been a tool that we are using because we are a low-end resource hospital as a government hospital. So obviously, if you have resources, you can do more. The other, of course, is opioid-free anesthesia. That is something that makes a huge difference. So something that I used to sort of do when I was sort of in cardiac, especially the cardiac patient, was to ask them if they read any books. Just ask them if they read a newspaper in the morning, read any book. That gives you a very good idea about whether they would be prone for any of these problems. And obviously, if you can have a bottom line that yes, their cognitive function is not impaired, then anything after that impairment is definitely POCD and post-op delirium. Management, non-pharmacological, yes, plenty of things you can modify. Or the latest newer ICUs have some of our old things. Of course, we had one side of the wall which is open to sunlight, so we would try to take them there once in a while and put some headphones for the patients with the family members talking to them or playing them some songs that they were their favorites after we asked the family. So lots and lots of non-pharmacological methods that you can, especially disturbance in the night by monitors, nursing staff. That's something that I hate. I keep telling them, don't wake up a sleeping patient and take their ask them if they're pain free. If he is pain free, he is sleeping. So you don't have to record pain scores when they're fast asleep. So something like that. Of course, now we are so adapted using the ultrasound for giving blocks. So any anesthetic which can be accompanied with a block should be accompanied by a block. And hopefully, if we get some liposomal bupivacaine, we can make it a long-standing pain relief so that you don't even need to administer any other molecule. And of course, dexmedetomidine, rightly like Dr. Neha said, very, very useful molecule if you use it properly. Bradycardia hypertension is very common in the elderly. So please be careful. No bolus doses, just an infusion and it makes a difference. I was a little surprised with one of her the alcohol withdrawal thing where she showed diazepam as the starting molecule for treatment. I'm not too sure that is still valid. So please, I wish to be corrected, but I
We'll
think
get back. We'll confirm that.
yeah, please. So that
Thank
is
you for
something.
pointing out.
So wonderful, nice talk. I mean, I'm learning.
Thank you. Thank you so much for your kind appreciation. We'll move on, sir. Topic is post-operative risk.
Topic is on post-operative respiratory failure and advanced ventilator settings by Dr. Sunil T. Pandya, sir. No introduction is very familiar in the academic world, but however, I would start with a brief introduction. Sir did his MBBS and MD from Osmania Medical College and did cardiac anesthesia from co-founder and director at PACS, the past president of AOA, yeah, and currently heads the Department of Anesthesia, Perioperative Medicine and Surgical ICU. Over to you, Sunil sir.
Thank you. Thank you, Kiran, and thank you, Dr. Gopinath, sir, for next. What will operative. How do we define incidence and people average length of stay up to 11 days, which again has a substantial increase in the cost of hospitalization. And if you look at the incidence of PORF, it ranges from about 2.7 to 3.4%. And unfortunately, if the PORF proceeds to ARDS, it leads to high mortality as high as 25%. And importantly, the post-operative pulmonary complications have been undermined and more important given cardiovascular complications in the post-operative period. But yes, with the people that twice as common as cardiovascular complications are underappreciated, and we need to have a focus. How do we define PPC? How do we define post-operative respiratory failure? The AHRQ has defined PORF as a failure to wean the patient on mechanical ventilation within 48 hours of the surgery or unplanned intubation or reintubation postoperatively. The European consensus on the perioperative clinical outcome, they define PORF as an entity where the PaO2 is less than 6 of mercury in the room air, or the peripheral oxygen saturation and pulse oximeter is less than 90%, and the PF ratios are less than 300 millimeters of mercury using oxygen therapy. And this guideline does not consider the ventilation or reintubation in this. The severity of PORF again can range from transient hypoxemia to early post-operative period in the leading to ARDS in post-life-threatening form. And importantly, the respiratory failure occurring secondary to the cardiogenic pulmonary edema not included in both. You need to keep in mind that the respiratory failure is purely because of respiratory issues and the cardiac causes have been. Well, we know the different etiology which has been elucidated nicely by my colleague Dr. Mayura. The respiratory muscle dysfunction that can happen because of anesthesia, because of surgery, because of the Thompson's retractor with the surgeon use, especially the subdiaphragmatic retractors, and at the time of emergence from anesthesia, the negative pressure pulmonary edema, which can lead to a worsening of perioperative respiratory complications, and importantly, atelectasis, which itself can be because of anesthesia, supine position, upper abdominal surgeries, thoracic surgeries, long duration surgeries. Multiple causes have been there. Importantly, we know that atelectasis leads to reduction of all the diameters, the volumes of the lung, the thorax diameter, the airway dimensions. Importantly, increasing the VQ mismatch and causing hypoxemia. Atelectasis can be triggered not only by anesthesia but also because of surgical incision. Again, the type of incision, the bilateral, like Mercedes-Benz incision, which the subcostal region is the maximum, when preceded by thoracic incision. Importantly, prolonged use of diaphragm, like especially the Thompson's retractor, supine position, surgical duration more than 2 hours. All these things increase. And importantly, if we don't manage operative pain and the pain like post-operative pain, the inflammation and all these things increase, so that it's on an logarithmic scale. Atelectasis is going to increase, end up with collapse, and subsequently the patient may end up on ventilatory support, invasive ventilation, because they may not respond to non-invasive ventilation as well. So basically, the atelectasis that occur in the post-operative period has been described as a multiple hit theories, where the patient gets hit multiple times and leading to logarithmic expression where the patient can go into ARDS like situation. So as I said, yes, during emergence intraoperative period, we can take care by what Dr. Mayura said, by intraoperative lung protective strategies. We can optimizing opioid free anesthesia, as has been said by Dr. Gopinath, the previous discussion. Yes, you can opioid restrictive policy is one thing that we need to keep in mind, that we can keep our patients intensely analgesic by giving intense sensory analgesia by regional blocks, at the same time minimize sedatives, including benzodiazepines, and more importantly, the recurization has to be prevented. We know that the current usage of cisatracurium, atracurium has reduced the incidence of recurization by almost about 20%. If you look at the incidence of residual neuromuscular blockade or recurrentization is almost up to 40 to 50% with conventional long-acting neuromuscular blockades. But with the Hoffman degradation, which we see with atrium cisatracurium, this incidence has been curtailed to 8 to 10%. We can reduce it further by the newer reversal agents that we have in our practice, fortunately are available last couple of years, the sugammadex and rocuronium combination, where you can completely reverse the neuromuscular blockade without any significant residual neuromuscular blockade. And of late, last 1 year, we've been practicing complete recovery after anesthesia and enhanced recovery after surgery from the point of extubation. Very important. Further, it is very important, the onus on the part of the anesthesiologist who does PAC, that patients who come with obesity, OSA, COPD, smoking addictions, major surgery or polytrauma, and nerve palsies, especially pre-existing nerve palsies, hemodiaphragmatic palsy, or patients on prolonged bedridden or restricted mobility, they are the highest risk for post-operative pulmonary complications, as has been said by again Dr. Mayura, the LIP study and the EALS study and other studies. So basically, if you look at the incidence of ARDS, like PORF converting to ARDS, the incidence is 0.2% in general surgical population. But when the patient undergoes a high-risk surgical procedure, it may go up to 13 to 7.8%. And as Gopinath has said rightly, in cardiac surgery, it is almost about 10.2%. And these are the Berlin's definition of ARDS, where you categorize, depending on the PF ratio, as mild, moderate, and severe. So, how do we define post-operative ARDS? Well, symptoms that occur within the 1 week after surgery and or worsening of pulmonary symptoms within from the 0 day or the first day after surgery is one of those really important thing. Clubbed with bilateral opacities in the lung, which are not fully explained by the effusions, or whether they are associated with any lung collapse or lung consolidation, is considered as post-operative ARDS. And PF ratios typically are less than 300 with a PEEP of more than 5 centimeters of water, and they cannot be attributed with the cardiac issue. That has to be kept in mind. As I said earlier, the post-operative pulmonary complications causing PORF, causing ARDS, has multiple hits. The first hit is the patient initial stage itself. Either the patient comes with the bundle of comorbidities, or because of the anesthesia surgeries, or because of the primary hit from the surgery, long surgery, upper abdominal surgeries, thoracic surgeries, so on and so forth. And the secondary hit can happen because of the changes or dynamics that can happen in the perioperative period in terms of full stomach aspiration or inappropriate fluid therapy, where you overload the patient, causing fluid overload, or inappropriate transfusion, a very poor blood management system. Earlier discussion in webinar one, my colleague Dr. Chandu discussed very well about the patient blood management system, wherein elective surgeries, planned surgeries, if the patient is anemic, don't take up the patient with perioperative transfusion. Rather than that, stabilize the patient, improve the hemoglobin preoperatively, and then take up the patient for surgery, so that you can minimize intraoperative transfusion. Because we know that intraoperative transfusion, post-operative transfusion itself can cause reduction in immunocompromised individual, and importantly, it itself can cause, even a single unit of transfusion can cause rally, which we have to keep in mind. So fluid therapy, transfusions have to be kept in mind as a topmost priority. Inadequate infection control policies. Again, fortunately, we have a very stringent SSI prophylaxis, but that is something that we need to follow diligently, that prophylactic antibiotic for surgical prophylaxis is given at least 30 minutes before skin incision. Itself can reduce post-operative bacteremia and sepsis. Post-operative atelectasis because of trigger on inflammatory reaction. Again, poor intraoperative ventilatory strategies and poor post-op pain management can worsen the biotrauma, and this has to be minimized. The same thing, intraoperative ventilatory strategies, has been elucidated by Dr. Mayura. So how do we risk stratify this patient? Yes, the first stage, the risk associated with the patient comorbidities, it's up to us for preoperative optimization. And second stage also, we can modify to an extent by our intraoperative anesthetic management. If you look at the causes of patient death, like let us say following colorectal surgeries, Majority of the time, the patient dies not because of surgery or surgical complication. The patient dies because of pre-existing comorbidities. So optimization of patient is of paramount importance. And these are all the risk factors again, which has been discussed earlier. The elderly, like elderly age, the geriatric age are the more prone. The history of COPD, functional dependence, hypoalbuminemia, ASA grade 3 and above, emergency surgeries, and referral from other centers. So it is very important that whenever you get a high risk patient, preoperative optimization, stabilization is very, very important. Has been emphasized by my earlier speaker and previous webinars also, that routinely we follow in our hospital the new regime, the nutrition, building up of endurance, allaying worries and anxiety, smoking cessation even for a day is helpful. So preoperative OTT again is optimization, titration, and transition, not the OTT platform that we use during our entertainment hours. But importantly, OTT is very important because this is the window that you take to optimize the patient. Patients who are on beta blockers, patients who are on ARBs, the transition from ARBs to short-acting antihypertensive, that patient we don't have any worsening of intraoperative hypotension or decent glycemic control. HbA1c more than 8.5 for elective surgery should not be taken, because just by merely controlling sugars for 2 days and 3 days and taking up the patient with FBS of FBG of less than 120 should not be the goal. You need to postpone this patient at least for 4 to 6 weeks so that you can bring down the HbA1c to less than 8.5, so that the leukocyte function is improved and you can minimize the perioperative infective risk. It's very, very important. Bridging anticoagulants again has been discussed earlier, but importantly, fluid electrolytes correction is very important, especially for hepatobiliary. We don't do much, but patients who are on who require ileal pouch reconstruction or colonic surgeries, they may require bowel preparation, purgatives, osmotic laxatives, which can cause fluid electrolyte imbalance, and that has to be appropriately corrected. So, as I said, patient blood management is very, very important to minimize perioperative transfusion. And building up nutrition is very, very important, because all these things have been mentioned can help and can minimize postoperative pulmonary complications, especially if you have a patient who is cachectic, who doesn't have any muscular reserve, who don't have enough strength to do spirometric exercises. They are the highest one, and many of our patients who are on necrosectomies, who require necrosectomy, laparotomies, re-laparotomies, who have been in ICU for more than 2 months, and they have very poor outcome unless you stabilize and strategize. So preoperative plan is very important. Preoperative optimization, nutrition is very important. Enteral preferably, or parenteral also if enteral is not tolerated. But importantly, intraoperative organ protective anesthesia, very important. Lung protection already has been discussed in detail, but organ protective anesthesia is nothing but minimizing sedatives, minimizing opioids. Opioid restrictive policy is what we have introduced, like opioid stewardship program we have introduced, to restricting, minimizing long-acting opioids, preferably avoid morphine, usage of morphine by giving more of regionals, intense sensory block, and targeted fluid therapy. Again, a word about targeted fluid therapy, especially long surgeries, major hepatobiliary surgeries, where you see massive blood loss. This thing, don't overload the patient. Put a TE probe. We are fortunate to have Dr. Lakshmi, who is a cardiac trained, certified echocardiographer. We have a low threshold to put a TE probe and monitor and titrate the fluid therapy, targeted fluid therapy, or even have a low threshold to put a flow track. Yes, all these things comes at a price, they cost to the patient. But remember that even 1 or 2 days stay in ICU, it counterbalances this cost. So you just have to keep in mind. And refinements of surgical techniques continuously happening, like go for minimally invasive or robotics, so that you can minimize the open surgical time. And ERAS has to be followed universally, so that we can minimize the post-operative complications. So fluid titration is very, very important. Intraoperative trauma, pyrotrauma, volutrauma is of paramount importance. So lung productive ventilation, as has been said earlier, PEEP adequate PEEP, and especially the patient in Trendelenburg tilt, then you need to optimize the PEEP further, and at the same time avoid overexpansion or overinflation of the lungs. Very important. So anesthetic technique are the core in management, already has been discussed, but more importantly, emergence from by using short-acting neuromuscular blocking agent like intermediate-acting like etricurium or citracurium, clubbed with neuromuscular monitoring, you can optimize rather than giving every time bound or continuous infusion. You can just monitor the NMT. And we have realized that earlier NMT was not a standard tool in our hospital, but after coming here, NMT and BIS become a very standard monitoring routinely almost for all the cases we use it. And now we know that you can minimize the dosage of anesthetics, the inhalation anesthetics, the intravenous anesthetics, including neuromuscular blocking agents by almost about 30% if you go monitor titrated anesthetics. And emergence can be a smooth emergence, and especially with the newer cyclodextrin complex available, it can be a complete recovery after anesthesia, and the patient can walk from the time of from the point of extubation. That's what we have been practicing, the ERAS E, uh, making the patient walk from the time of extubation. What we have achieved by doing this is not that we have improved the outcome, but 0 day ambulation, 0 day sitting, 0 day spirometry, or I would say 0 hour ambulation, 0 hour spirometry is what is important, because we know that if we expand the lung when it has collapsed immediately after extubation, it is always easy to expand. So our dictum is same: expand the lung and keep the lung expanded. So early mobilization, ambulation is of paramount importance. These are other things that have been mentioned as a part of preventive bundles, like antibiotic prophylaxis, oral decontamination, brushing of the tooth. Dr. Dayakar, my colleague, is very particular that patient does not come without brushing the teeth. And importantly, endotracheal tube management, over-inflation of cuff. So the moment you put a tube, check the cuff pressure so that we don't over-inflate the endotracheal tube. And importantly, avoid rigid tubes so that the soreness and other things can be minimized. And unnecessary nasogastric tube placement should be avoided, because we know that putting the nasogastric tube itself can reduce the tone of lower esophageal sphincter and can precipitate or predispose the patient to microaspiration, which can be deleterious. What about COVID-19 and post-operative respiratory failure? COVID has taught us many, many lessons. We have lost many of our dear friends. But importantly, what we have realized is COVID also, especially patients who have suffered from COVID, having moderate to severe or even milder varieties, the incidence of post-operative pulmonary complications has been high. And especially currently, yes, we are pandemic has been called off, but patients who come with COVID or who have symptoms of influenza, better to postpone elective surgery till the patient resolves, because presence of COVID, the mortality, if at all they develop COVID in the post-operative period, is significantly high, and we need to keep that in mind. Non-urgent patient who have been infected, surgery should be deferred at least for 4 to 6 weeks, and non-operative treatment should be given, especially if the patient is very high. And if at all the patient has COVID, symptomatic, then better to defer surgery for at least 7 weeks. Symptomatic, if the patient develops COVID pneumonia post-operatively, the severity should be individualized, and pharmacological treatment should be specific to the individual, because the newer modalities, they're all giving glucocorticoids in a surgical patient may not be safe. It can cause delayed wound healing, and all risk versus benefit has to be weighed in mind, and the most current treatment guidelines should be followed, involving a pulmonologist who has more exposure to COVID patients. The right treatment can be given is appropriate. So prevention is always better, and as I said, prevention of PORF is one of the things. Is so we, as I said, we have upgraded our PSC clinic. Hand anemometry is routinely monitored for all our patients, and currently we are correlating that the hand anemometer strength, the amount of pressure he is able to generate, is clinically correlated with the musculoskeletal strength. And what we have initially noted, now the study is ongoing, what we have noted is if the hand anemometry grip is good, the musculoskeletal strength of the thoracic cage also is good. And if in the absence of lung parenchymal diseases, the hand anemometry directly correlates with the pulmonary function test. And this is what we are doing a study now. And the PAC clinic, we also do the baseline incentive spirometry, how many balls he's able to raise, and how many balls he's able to sustain raise is there for how long. Also the blowout procedure, like force expiration, how many balls he's able to raise. And if the patient has reactive airway, we also have a look at the peak expiratory flow rate. So hand dynamometry, measuring PEFR and measuring incentive spirometry, baseline and educating the patient makes our job very easy because they also have what baseline strength they have. And if the patient is suboptimal, if the inspiratory flow is less than 800 ml per second, the peak inspiratory flow rate on the incentive spirometry, then we subject them for endurance building up, the resistive exercises if possible. If the patient is fit enough, and we train them for aerobic exercises under the guidance of a trained physiotherapy. So this thing is very important, and we are very fortunate the support from the management that we get. We are successful in implementing ERAS for almost all the patients. And again, during the COVID period, we did two fantastic studies. Almost they have come to the conclusion level. One was opioid-free anesthesia and has it hasn't ERAS in surgical patients. Another study is impact of new regime on prevention of post-operative pulmonary complications. Both these studies have been CTRA registered and they have thrown a lot of light. And now we are very comfortable to make our patients walk right from the point of extubation. Like we have introduced CIRA, the complete recovery after anesthesia without neuromuscular blockade to the maximum extent possible in select group of patients. Yes, not all patients they come under fitness of this category, and also ERASI. And these things have to a large extent reduced postoperative pulmonary complications. Again, adopting to targeted infusions. So to targeted controlled infusions, the PCI, TCI pumps, so that you can optimize the medications to the need of the patient, tailoring to the need of the patient. So that earlier we are giving empirically propofol 10 ml per hour, 8 ml per hour, 5 ml per hour. Now we can titrate how much dexmedetomidine we want to give, how much propofol we want to give, so that the patient wake up at the desired time. And all these things help us to guide us properly. As I said, objective measurement is what we are doing, like checking the hand grip before surgery, how much strength you are getting, and we try to aim for the same grip or the same strength immediately after recovery. You can see this patient is a grade 2 patient for lap chole before induction of anesthesia and immediately after extubation, what is the strength. So basically, the point which I want to emphasize is, of course, these are the clinical metrics, but they are nevertheless they have helped us in early ambulation and importantly minimizing post-operative pulmonary complications. Like this was a patient with hemicolectomy. You can see a beautiful response. Is able to raise 3 balls within 2 hours. This was under combined epidural plus general anesthesia. But doing these procedures of incentive spirometry within 2 hours after surgery, you can say TPCs can be minimized, and as far as possible, we try to keep our patients upright posture and wheelchair ambulate, even though they are on, despite they are on supportive ventilation. This is the patient with necrosectomy. You can see emaciated, making him sit on the chair because the proper position itself is enough for lung recruitment to happen. And this was again another 95-year-old gentleman who underwent lap passage hemicolectomy. This was one of the oldest patients that we subjected him for like CIRA and GARA, like ERAS-E. Within 1 hour, he is ambulating. And you can see the recovery. Immediately post Sugomadex, the BIS came to normal and the neuromuscular recovery was almost more than 100%. So there was no residual blockade. The point which I want to emphasize is intraoperative management of neuromuscular blocking agent, the recovery, the emergence process, the titration of sedation, the titration of opioids, the short-acting opioids, more intense sensory analgesia. All this helps us to minimize post-operative respiratory failure. And Dr. Kiran, my colleague who is in charge of surgical ICU, he's very fond of intermittent NIV and HFNC in patients who have prolonged surgeries for some reason, like long duration laparotomies or long duration hepatobiliary surgeries or Whipple surgeries that go generally, Whipples generally we finish up within 4 to 5 hours, but sometimes edematous pancreas, they take a little longer time, 6 hours. And when such a thing happens, prophylactically, he starts NIV for these patients, and provisional data says even the studies, they don't prove that prophylactic NIV helps, but our inference is that prophylactic NIV at least keeps the lung alveoli inflated and it helps. So BiPAP NIV definitely reduces atelectasis, and HFNC. A word about HFNC, uses the high flows. Roughly for every 10 liters of flow, 1 centimeter PEEP is exerted, and generally 50 liters is what we use, and PEEP of 5. But again, HFNC, if the patient is opening the mouth, the PEEP is no longer there. But one advantage of the HFNC is the patient can do breathing exercises, pyrometric exercises while HFNC is on, so that it helps in mobilization and helps in clearance of secretion. But word of caution with NIV, do not delay definite intubation and mechanical ventilation, especially if the patient is not maintaining saturation with high end positive pressure ventilation with non-invasive ventilation like and a bi-level PAP, BiPAP, because delaying intubation definitely increases the mortality proportionately. So if the patient does not hold on or maintaining saturation with high FiO2 and high PEEP with non-invasive ventilation, then intubate early rather than intubating late, because intubating late definitely have increased mortality from ARDS. So that has to be borne in mind. So NIV has a word of caution that has to be kept in mind. This was study by Villani et al., where they said that delayed intubation by even 6 hours, patient who merits intubation results in a proportionate increase in mortality. Unsafe, as I said, intraoperative, avoid overhydration. So euvolemia is what is our target is. Minimize transfusion, minimize TACO, and conservative fluid strategy. If at all your patient has massive blood loss, you have given excessive fluids, then measure the fluids post-operatively, and if necessary, if the patient is fluid overloaded, or then go for de-resuscitative strategies by giving furosemide, so that drain out the policy, maintain negative fluid balance or zero fluid balance, zero positive fluid balance on the from first day onwards. Very, very important. De-resuscitation is very important. Adjunct therapy in ARDS like glucocorticoids. So again, as I said, you have to weigh risk versus benefit, especially established ARDS, post-operative ARDS. Glucocorticoids have to be used cautiously because it can prolong wound healing. Nitric oxide has no role. In fact, nitric oxide in post-operative ARDS can worsen acute kidney injury. Neuromuscular blocking agent, already been said, does not have any say or does not have any, unless the patient is very high and you need to optimize stiff ARDS. Physiotherapy is the crux. Huffs and puffs are very important in clearance of secretion, but more importantly, it is very important that it is started within 2 hours. And this is what we aim by complete recovery after anesthesia and ASE. If the patient does not walk, at least they'll be able to do. And we know that if the spirometry is initiated within 2 hours after a major surgery, the incidence of PPC is very, very less. And this is what has been told earlier. Mechanical ventilation in prone ventilation following stiff ARDS or severe ARDS definitely is helpful. We know that it homogenizes the ventilation perfusion, minimizes V-Q mismatch for different reasons, various reasons, but importantly, have a low threshold to prone the ventilation. The newer modes of mechanical ventilation like airway pressure release ventilation, inverse ratio ventilation, the NAVA, the ESV have not, including HFO, high frequency oscillation, they have not done any good for post-operative ARDS management. But yes, if the patient does not improve, if the PF ratios are less than 100, despite prone ventilation for 24 hours, as per the PROSIVA trial is what we follow, have a low threshold to initiate ECMO, or if you don't have facility, stabilize the patient, transfer to a higher center. But this is very essential because especially if the insult is a recoverable insult. The patient is a terminally ill with major surgery, then yes, again, a very, very expensive thing, but have a low threshold. This was an algorithm that was published in this clinic where if the patient has underlying ARDS following post-operatively, the PF ratios are low, then prone ventilation is strongly recommended. If the patient has desynchrony, then neuromuscular blocking agent, high PEEP strategy should be considered, and inhaled pulmonary vasodilators like epoprostenol can be used. Recruited maneuver should be regularly used. If the PF ratios are improving, continue the same management. If the PF ratio they don't improve, then they definitely you need to go for ECMO. But if there are contraindication, consider ECMO. Adjunct therapies like steroids can be given, especially in the first 10 days after ARDS. Risk versus benefit has to be weighed. But yes, ECMO is an option. So to conclude, I would say that lung protective, preoperative stabilization, lung protective ventilation, intraoperative lung prevention strategies, and judicious volume administration are the crux. SIRA and ERAS-E are the new things that we need to embrace and practice. Multifactorial chest physiotherapy is definitely helpful, especially if started within 2 hours after major surgery. NIV helps in reducing incidence of tracheal intubation, especially for mild to moderate PPCs. And proning is important, especially in moderate to severe ARDS, have a low threshold. Thank you very much for your patient hearing, and I would love to hear from Gopinath sir his comments on these topics. Thank you very much, Kiran.
Wonderful. I think you have highlighted the importance of maintaining respiratory strategy in the perioperative period to provide or prevent post-op respiratory complications and failure. Something, I mean, it's common in the first talk, I guess, but at the end of the day, obviously restricting the use of neuromuscular blocking drugs, or at least completely antagonizing them with specific antidotes like you said, Sugammadex you're using very commonly. We have started using the same now, albeit without NMT monitoring. But I mean, it's nice to have a good pre-anesthetic updated clinic where you're looking at components of frailty and post dynamometry as well as incentive spirometry, because for you to implement protocols like ERASI and CIRAP, you require to have a baseline investigation.
Absolutely.
So TIVA is a wonderful way of doing it, or if you can't, at least give one dose of intubation and continue with TIVA so that you can avoid residual neuromuscular paralysis. So that is something that is a very common thread in terms of respiratory failure in the post-op, especially the elderly or the frail or the sick patient. Mostly surgical gastroenterology or GI surgeries who are nutritionally deficient and things like that. We have used HFNC not at such high flow rates, but at about 15 to 20 liters with 2 flow meters, even when transporting the patients. And we have done one ultrasound at the bedside as soon as we extubated and repeated it in the post-op period, and seen that the post-op pulmonary complications it was a not very large study, but yes, there is a definite reduction. So the use of ultrasound in the immediate post-op or in the immediate pre-op period also, maybe we were trying to look at airway and lung as a component in preoperative visit itself, but to get a ultrasound machine in the preoperative area is difficult. So on the table, yes, you can just put a probe and look at the various regions of the lung, and it gives you a very good idea about if a patient stops behaving well. So use of ultrasound in the post-op also to rule out pulmonary complications will be an important tool. So TIVA, preoperative or prehabilitation, like prehabilitation is a luxury because you need some time for that. But at least objectively measuring all the parameters as well as continuing the same in intra-op and post-op. So congratulations for implementing the ERAS-E protocol. We look forward to see it as a publication.
Yeah, sir, we are in the process. Thank you very much, sir.
Wonderful.
Before moving on to the next topic, I would like to talk about the concept and evolution of ERASI. Actually, it was Sunil sir's dream few years ago to make walk from right from the OT table to the post-operative area, but it was made possible because of the introduction of Sugammadex and with the help of our colleagues Dr. Sai and Dayakar. I must acknowledge them. And one lab colleague, one uneventful procedure, and Sugammadex was given, was fully awake, obeying commands, moving all limbs, and is completely stable. And that's when we made the patient walk from right from the OT to post-operative recovery area without with minimal support. And that's when Sunil sir came with the concept of ERASI, right from the extubation, and he coined the term ERASI. Let's move to the next topic. Acute kidney injury and RRT, a review and update for the perioperative physicians by Dr. Neha Megun.
Yes, good evening. And on to the last topic of the evening. I hope I have your attention. So AKI and RRT, let's begin with a case report. A 27-year-old male with history of fall from height with multiple facial fractures, flail chest is posted for fixation of femur fracture. Patient has reduced urine output that is less than 0.5 ml per kg per hour for more than 6 hours post-surgery with tachycardia and hypotension. So what would be your first strategy for managing this? Would you go for assessment and correction of hypovolemia? Would you go for a CECT abdomen? Would you go for initiation of inotropes or an ABG and proceed for RRT? So to answer this, let us first dive into the concept of AKI, definition and criteria and management. So acute kidney injury is defined as an abrupt decrease in kidney function which encompasses both injury and impairment. Incidence is in communities, it's 4.3%, which increases up to 60% in critically ill patients. It was called as Ischia renalis in 1802, in World War I, labeled as war nephritis, World War II as Crush syndrome. In 1951, it was called as acute renal failure in relation to traumatic injuries. In 1918, the term AKI was coined in terms of mercury poisoning. In 2002, the ADQI Society was referred it and moved beyond the concept of ARF to AKI. And then they came up with the Rifle criteria to diagnose AKI. Rifle criteria has 3 classes to assess the severity of AKI and 2 outcome classes. 3 classes being risk, injury, and failure. As clinicians, as ICU physicians, as anesthetists, we need to look at the risk class. When we identify a patient, when the patient is in the risk class, that is when we know that the patient is going to progress to AKI. That is where we intervene, and that is where we can save the patient. So all these criteria are based on serum creatinine, GFR, and urine output, which take time. The creatinine takes time to be detected with a delay of around in hours and days. The Rifle criteria was developed in 2004, where the risk class was defined as more than 1.5 times rise in serum creatinine within 7 days. Now, to increase the sensitivity of this criteria, AKIN criteria, that is the Acute Kidney Injury Network criteria, was developed in 2007, where the criteria was reduced to 48 hours, a more than 0.3 milligram per deciliter increase of serum creatinine within 48 hours. KDIGO criteria in 2012 encompasses both Rifle criteria and the AKIN criteria, and it also comes up with a rise in serum creatinine, absolute rise in serum creatinine of more than 4 to define failure. So we all know the causes of AKI. I would not dive much into it, but the 3 main causes which as anesthetists we need to be wary about is hypoperfusion, sepsis, and use of nephrotoxic drugs and contrast. Pathogenesis of AKI, ischemia, toxic injury, and sepsis can induce inflammation, vascular injury, and tubular injury, leading to cell death, necrosis, apoptosis, and leading to endothelial dysfunction, microvascular obstruction. Now, an important concept that we need to know about is crosstalks. All our organs are in sync with each other. So as AKI induces pathological effects via cellular and soluble mediators damaging the other organs, when they are affected, they can also produce AKI. So acute lung injury, acute worsening of hepatic cardiac functions exacerbate kidney injury via metabolic and biochemical derangements. What are the risk factors for AKI? An elderly patient undergoing an emergency surgery with uncontrolled blood sugars, with extremes of blood pressure variations intraoperatively, with a low venous compliance. All these are factors which can contribute to AKI. A word about contrast-induced AKI. Most of the AKI that occurs post-contrast period is contrast-associated. That is, there are some other attributable factors to AKI that develops post-contrast. So particularly contrast-induced AKI has a very rare occurrence. It usually develops within 24 to 48 hours of iodinated contrast. The contrast that we use nowadays are usually low or iso-osmolar contrast. Earlier, the high osmolar contrast was used, which is no longer used. And the pathology is direct tubular damage or causing renal vasoconstriction or oxidative stress. To prevent it, you should try and avoid contrast on all the high-risk patients. Discontinue metformin or all the nephrotoxic drugs prior to giving contrast. So metformin, because it can lead to lactic acidosis and can worsen the acidosis in CKD patients. Careful volume expansion. Overnight hydration in a euvolemic ASA1 patient, but in patients who are on dialysis with CKD, go for careful volume expansion since the patients can go into volume overload. There is no role of N-acetylcysteine, no proper proven role of N-acetylcysteine, bicarb, or diuretics in post. The KDIGO has guidelines for management of AKI. In grade 1, you go for discontinuation of all the nephrotoxic drugs when possible, ensure volume status and perfusion pressures are maintained, go for functional hemodynamic monitoring, monitoring serum creatinine and urine output, avoid hyperglycemia, use diagnostic workup, and go for, when the patient develops a stage 2 or 3 AKI, consider ICU admission and RR. So to answer the question, a case of polytrauma has reduced urine output for more than 6 hours and has tachycardia and hypotension. Sorry, I missed 6 hours here. So what would be your first strategy? All the strategies are can be implemented, although the best strategy would be assessment and correction of hypotension. Perio pathway for at-risk patient that we follow here. So what all can you do when you know that your patient is at risk for AKI? We need to optimize anemia and other comorbidities. We keep a hemoglobin target of 8 for such patients. Go for sugar control and optimize volume status using isotonic crystalloids. Remember that colloids have no role. Cardiac output monitoring intraoperatively and glycemic control. Maintain sugars of less than 180 post-op and target a higher blood pressure with a MAP of 80 to 85 SFP. Remember that keeping a low blood pressure target or keeping hypotension for more than 10 minutes intraoperatively can predispose your patients not just to AKI but to stroke and cardiac distress. Coming on to RRT, let's start with the case report. A 65-year-old man post CABG with an ejection fraction of 35% post radical nephrectomy is posted for emergency laparotomy. So this patient is shifted to ICU on noradrenaline and vasopressin support and maintaining a MAP of more than 70. Patient has been shifted and the X-ray, ABG and ultrasound are suggestive of pulmonary edema and left ventricular failure, and patient has nil urine output in the last 2 hours. How would you proceed with? Would you increase the IV hydration in lieu of reduced urine output? Would you give Lasix or furosemide stress test to the patient? Would you add adrenaline, maybe increase the MAP a little more and cause maybe that would increase the perfusion? Or would you consult nephrology and plan a CRRT? We'll discuss the answer a little later. Renal replacement therapy. It's a therapy that replaces the normal blood filtering functions of kidney. This is like an artificial kidney or the organ support. What are the indications of RRT? Explained by the mnemonic AEIOU. A stands for metabolic refractory metabolic acidosis, E for refractory hyperkalemia or hyperphosphatemia, I for drug ingestion, refractory fluid overload by O, and uremia, azotemia, and its complications like encephalopathy, pericarditis. What are the drugs that are dialysable? So to note, the important drugs are beta blockers, metformin. In patients who are posted for emergency surgeries and are on dabigatran, high bleeding risk. Remember that dabigatran is dialysable and can benefit from a cycle. Then V stands for valproate, the anti-epileptic drug, vancomycin toxicity. Refractory hyperammonemia. So this has been used in our own ICU where a patient of CLD with refractory hyperammonemia, all other treatments had failed, patient had developed cerebral edema and low GCS, and dialysis was effective in weaning him off the ventilator. What is the basic concept of dialysis? So dialysis filter is composes of hollow tubes. There are hollow tubes inside through which the blood flows, and the dialysate is right outside those hollow tubes, right? So how does the dialysis occur? It occurs either by diffusion or convection. The diffusion is when the solute moves from a high concentration gradient to a low concentration gradient. The urea and creatinine that are present in the blood are going to move into the dialysate fluid along a concentration gradient. In convection, there is pressure applied on the dialysis chamber, and that causes the solvent to move out. So the solvent moves out through the dialysate filter, and along with it, it takes a solute out with it. So these are the two methods how solute clearance occurs in dialysis in renal replacement therapy. So diffusion causes the removal of small molecular weight molecules, whereas convection is responsible for removal of small molecular weight as well as the middle molecular weight molecule. What about the large molecular weight molecule? So for that high molecular weight, we have plasmapheresis that is usually used in autoimmune diseases or metabolic diseases like thrombotic thrombocytopenic purpura, Guillain-Barré syndrome. Remember, it has limited role in fluid removal. What about solvent clearance? Solvent clearance occurs mostly by ultrafiltration. Now, when you're clearing solvent, it is not just a few ml of fluid that is going out. You're clearing liters of fluid from the body. So that can lead to hemodynamic instability, and to replace that, you need a replacement. So the replacement can be done either pre-dilution or post-dilution. So when it comes to pre-dilution, you dilute before entering the filter. Dilutes, so this pre-dilution dilutes the solute as well. So it's not only the replacement that you're occurring, it also dilutes the solute. So you have lesser solute clearance by 15 to 20%. So to compensate for that, you need more blood flow is required for effective clearance. Because of the dilution, your filter is continuously flushed, and that prolongs your filter life. In post dilution, you dilute before it enters the patient. Here, because the filter is receiving hemoconcentrated blood, it can affect the filter life because the filter gets clotted and it needs anticoagulation that can be done using regional citrate heparin. So what are the different modalities of dialysis that we see in ICU? It's intermittent dialysis, SLED, or CRRT. In intermittent dialysis, now we all know the differences between this. So intermittent dialysis is for 3 to 4 hours, SLED is for 6 to 12 hours, and CRRT is 4 hours. Now, how do we differentiate? When you want dialysis for a shorter time, you want to remove the fluid rapidly, you want a rapid solute clearance, you go for intermittent hemodialysis, where the main mechanism of solute removal is diffusion. Fluid shift occurs by ultrafiltration, and because it's going to occur over a short span of time, you need a higher blood flow rate and a higher dialysate flow rate. So the blood flow rate is more than 200, dialysate flow rate is more than 500. The disadvantage of this would be hemodynamic instability that can. In CRRT, you go for a longer duration of dialysis. Solute shift mechanism is diffusion and convection both. It has a better removal of middle molecular weight solutes and a better hemodynamic stability. SLED comes in between the two, where you are worried about a patient who is on low dose of NORAD, for example, and you're worried that if I initiate IHD, the patient may become highly unstable. So SLED is such. Now, what are the types of CRRT? You have continuous veno-venous hemofiltration, continuous venous hemodialysis, and continuous veno-venous hemodiafiltration, where both dialysis and filtration are used to remove the solute. Another type, that is SCUF, that is slow continuous ultrafiltration, that's used only for solvent removal. So this is mainly used in patients who have developed pulmonary edema and cardiac. Another two terminologies that we need to know is the filtration fraction and the sieving coefficient. Filtration fraction is basically how much of percentage of plasma water is removed. It is a percentage ratio of ultrafiltration rate to plasma flow. So it should be kept less than 30% to prevent circulatory collapse. Sieving coefficient is the potential of different solutes to pass across a particular dialyzer. So if the sieving coefficient is 1, that means that your solute is 100% dialysable. Albumin has a sieving coefficient of 0.03. Now, to perform effective dialysis, you need a good functioning dialysis. So what is the major determinant of dialysis? It is the dialysis catheter dysfunction that occurs can affect your dialysis largely. So how do we prevent it? We use rigid to insert a pliable material once it enters the body. So his silicone is more biocompatible than polyurethane. We need double lumen with a diameter of at least 4 to 5 mm with adequate length. And the infection risk, that is lower with tunneled catheter with a permanent permacath or a site of insertion. So a site of insertion does not affect in a healthy normal weight normal BMI patient, but in obese patients, femoral has an increased infection rate. Also, there have been a study that is done that indicates that catheter dysfunction is higher with left IJV. So the site to choose would be a right IJV followed by femoral and then left IJV. Subclavian is avoided because of risk of canal stenosis, and that can be difficult when you want to put a fistula for the permanent dialysis. Catheter tip is usually kept at the superior vena cava and right atrial junction for better diagnosis. And the length should be at least 24 centimeter when it comes to femoral left IJV and 20 centimeter for right IJV. Any length beyond 24 centimeter can increase the chances of recirculation. Troubleshoot: when you have a dialysis catheter dysfunction and you have frequent alarms, you need to change the position of the patient, go for pre and post RRT saline flush, rotate the catheter, reverse the lumens, although continuous reversing can further inhibit dialysis. Check KT by V for intermittent dialysis. Fibrinolytic locks are not recommended, and changing the catheter is the last. Can you perform CRRT in absence of anticoagulation? Absolutely yes. By maintaining adequate blood flow, that is 100 to 300 ml per minute, use of pre-dilution more than post-dilution, keep your filtration fraction less than 20-25%, respond promptly to alarms, avoid overheating dialysate and replacement solution, prevent kinking and mechanical obstruction in catheter, and then there is a drip chamber where a saline drip is used to prevent blood air contact. In CRRT, we know that it goes on for 24 hours, so that continuous blood flow. So we have to use some form of anticoagulation. It can be in the form of regional citrate anticoagulation or heparin anticoagulation. Studies have shown that regional citrate coagulation a better filter patency. Where citrate solution is added to the blood and that is coming from the patient, and it chelates the calcium, and this calcium citrate complex, 40 to 60% of it is excreted, and the 30 to 40% that is left behind is low. The blood that is entering the patient is low in calcium, so we have to supplement calcium via another IV line and to target and systemic calcium of 1 to 1. Since the citrate complex also enters the body, it is metabolized by liver to bicarb. So in patients with acute liver failure or lactates or more than 8, regional citrate. The drawback of this is that it requires serum calcium and ABG monitoring and thus proves costly for the patient. Heparin anticoagulation, on the other hand, is more cost effective but has increased risk of bleeding and needs APDT monitoring. So how do you initiate dialysis? There have been studies done. There was a European multicentric study which shows that a positive fluid balance was an important factor associated with increased 60-day mortality. So you initiate a late dialysis, patient is volume overloaded, and the patient will have increased mortality. Similarly, a late dialysis, when the patient has already developed acidosis and concomitant other organ function, is associated with poor survival. A decline, another study by Anatol showed a decline of cumulative fluid balance during CRRT was associated with lower risk of mortality. A similar result was shown by the renal study. So there was a landmark study that came into picture, was the bicarb trial. In bicarb ICU trial, what they show is that if you add bicarb, if you administer bicarb, that the study was study uses a 4.2% of soda bicarb to maintain a pH of more than 73. That the patients who receive RRT, patients who receive RRT in the bicarb arm have lower requirement of RRT. That is only 35%, whereas the patients who do not receive bicarb have an increased requirement of RRT. Also, the secondary outcome, the mortality in patients who have developed AKI, is also reduced in the bicarb arm. So the study shows that bicarb is effective in reducing the patients who require therapy. Other studies that have come into picture are ELAINE trial, which was a one-centered trial, which was mainly done on cardiac post-surgical patients, which shows that early RRT is more effective. The rest of the studies were multicentric studies and were largely show no difference in early versus late initiation of RRT. These were basically based on early KDIGO classes 2 to 3 and time duration. And but one significant result that came out was that in patients who received early RRT, almost 98% of patients in AKK trial and 97% of patients in ideal ICU trial were given RRT, whereas late in the late arm in AKI trial and the ideal ICU trial, only 51% and 62% of the patients respectively required dialysis. So we, from this, we conclude that some of the patients have unnecessarily received dialysis in the early arm, which could have been saved. There is almost 50% reduction in the patient load who have received the late dialysis. So all these studies are based on creatinine and urine output and on rifle and KDIGO classes. So are there specific markers to induce kidney injury that we can use to know when a patient needs dialysis? There are specific biomarkers, cystatin C, which is more specific than creatinine. There is NGAL, which rises in the blood as soon as a kidney injury is ensured, and in 2 hours, and peaks at 5 hours, and at present for up to 5 days in the patient's blood. There was a landmark study that was done by Lakshmi Chawla et al. So this was a furosemide stress test. So compared with other biomarkers, FST has more area under the curve. That is, it has increased diagnostic. So it was based on the concept that when you give Lasix or furosemide to a patient, it goes via the blood, enters the nephron, enters the proximal convoluted tubule, loop of Henle, and acts on the sodium potassium chloride receptor in the thick ascending loop. So if your furosemide is able to produce its effect, that means all this part of the nephron is working, is functional. So in what category of patients do you use your furosemide stress test? It is used in adequately resuscitated euvolemic patient with persistent oliguria. So in patients who have received furosemide before, you go for 1.5 milligram per kg, and who are furosemide naive, that is, who have never received furosemide, you go for 1 milligram per kg IV bolus. And then you monitor the urine output in 2 hours. If the urine output is more than 200 ml, the patient is pre-renal oliguric. That is, if you attempt further hemodynamic manipulation in these patients, the patient may improve. And whereas in patients who have a lesser urine output, less than 200 ml, there is some intrinsic renal failure, and maybe hemodynamic or fluid or vasopressor or anatropes may not help, and the only measure out is RRT. So critical care patients are largely unstable, they are in hypercatabolic state, and dialysis may help in minimizing fluid overload and allow for other supports, like you can give more nutrition and medications to these patients. In a summary of this, early RRT offers no outcome benefit. Early RRT may worsen function, so you have to balance the likelihood of recovery with patients' need for ongoing fluid and other organ failure and expected solute burden. Incorporate furosemide stress test in decision making. So which modality to go for? CRRT is preferred in severe hemodynamic unstable patients, in patients with raised ICP, acute liver failure, patients fluid removal is not tolerated by SLED or intermittent hemodialysis, and patients who need a tighter metabolic control. How do you decide dosing in CRRT? There was a study in 2002 done by Schiffel that found that daily intermittent RRT was better than alternate day RRT. In CRRT, usually urea and creatinine are excreted as 1:1, depends upon ml of effluent that is coming out. And there was a renal study that was done which found no difference between high intensity and low intensity RRT. ATN study shows that in intensive arm, hypokalemia, hypophosphatemia are seen more. So when you prescribe a CRRT dose, it's usually prescribed at a little higher than what the recommended dose is, because patient tends to get interrupted in between. The dialysis does not necessarily continue only for 24 hours. It may be interrupted for procedures, for mobilization, and for back change. So what is the guideline? Current recommendations are KT by V, that is the ratio of KT by V. K is for the constant, T for time, and V for volume of distribution is 1.2 to 1.4 per session in intermittent hemodialysis. And in CRRT, since it depends upon effluent dose of at least 20 to 25 ml per kg per hour. Termination of dialysis. So when do you stop your dialysis? Furosemide, can you use a furosemide stress test for stopping your dialysis? There have been studies done that although furosemide did increase by continuous infusion, did increase urinary volume and sodium excretion, but it did not lead to shorter duration of renal failure or more frequent renal recovery. In the BEST study that was done, a urine output of more than 400 ml per day without concomitant diuretic therapy was a predictor of successful CRRT discontinuation. So there is no proven method of termination of dialysis. Intermittent hemodialysis, you can reduce its frequency as tolerated. In CRRT, switch to IRRT once stable. Most commonly used criteria to terminate dialysis is resolution of oliguria, resolution of volume overload, improvement in serum creatinine, and resolution of. To answer our question, in patient with volume overload with a low ejection fraction with pulmonary edema and left ventricular failure, my option choice would be to consult a nephrology and plan a CRRT. Thank you.
Dr. Neha for an RRT. I've just been tuning. Another thing that I would like to tell audience who are listening, don't be in a hurry to start RRT. Whatever. Red or CRRT reports can induce profound refractory hypertension can have cardiac arrest. RRT should be started only daytime when count, not at odd hours. I've seen patients in ICU 1 a.m., 10 a.m., 10 p.m. They free the dialysis unit they start and they just take out 150 ml of volume from the for initial that have to cause hemodialysis. Thus, that
Thank you, Dr. Neha. I think again, all the speakers, very comprehensive coverage of the subject. AKI has been mentioned for me in cardiac anesthesia, and of course, biomarkers are the way to pick up early AKI, like you mentioned, the whole list, so KIM1 and things like that. So obviously, early, though there are studies, especially in the critical care setting, which say that early or late RRT are do not or might not, but yes, in at least some settings, especially cardiac surgical, early intervention or early RRT does have better benefit because the insults are much more diverse, inflammatory response and embolic, so many other things. In the perioperative period, yes, you should have the concepts are the same for any vascular bed, pressure and flow. So yes, flow, kidney gets a lot of flow, so we use it as a marker of cardiac output. But the other issue, of course, is the pressure part. So please do maintain mean arterial pressures of 70 plus. By what means? Without compromising other circulatory beds. So that's very important. Metabolic markers are as good as early AKI markers for us to say that this patient is going for metabolic acidosis or whatever. So it's important that you recognize at an early stage. And of course, those who are already compromised cardiovascular, renal replacement therapy, others, yes, the furosemide challenge would be the best. We have had given patients even 200 milligrams bolus furosemide and started off infusion. So all of them have at various times in our practice been helped us to manage these patients. But like I vouch to what Dr. Sunil said, do not attempt all this after hours, after working hours. Either extubations which are planned or which can be planned, or the say unless there is an emergency, do not initiate or do anything that can jeopardize the patient's life. Thank you, Dr. Sunil. Thank you, Kiran. And thank you all the speakers for tolerating me.
it is always a privilege to have you, sir. You all more than what we are humbled. Thank you very much, sir. Before we conclude, I would like to thank my colleague. Yes, not to undermine the help and support that we get from the management, and who is the judge of academy, Mr. The ITT, providing us this platform, and of course the chairman, director. Are ever pleasing when we say that we want to do a CA all out and support. I thank every one of them. And again, sir, thank you very much for giving us more than 2 hours. This we know that things are all precious. We just have departmental activities, and that's when the last 2 hours of the day of our work, we look into the admin part of the department, and we have snatched away those precious hours. Thank you very much for being with us, and look forward to more such associations.
Thank you, Sunil. Bye.